I'm Kelly Johnson-Arbor. I am the co-chair of the MedStar System-Wide Patient Blood Management Committee, and I also practice hyperbaric medicine and toxicology. Today, I will be speaking on the bloodless medicine and surgery perspective with managing anemia without blood transfusion, but I thought that I would focus on IV iron safety today. I was discussing this talk with our bloodless medicine nurse coordinator, Richard Verstrate, and I was like, Dick, this whole meeting is on quality and safety. What can I do to be a little bit different? And he suggested to me, well, why don't you talk about IV iron? Because that's something that comes up in our bloodless medicine program at MedStar Georgetown all the time. So I'm going to talk about IV iron safety. I'll be delving into my medical toxicology background a little bit. So this may be something that's completely strange to some of you, but hopefully I won't bore you too much and get too biochemical on you. So, all right, so let's start this. So we'll talk about the uses of benzyl alcohol, both in pharmaceutical and non-pharmaceutical products. I will describe the gasping syndrome. And we'll talk about the significance of benzyl alcohol and its presence in IV iron formulations. And we'll talk about whether certain IV iron formulations are safe or contraindicated in pregnant women. So just a very quick review of iron hemostasis. Basically, we all know this. Iron is an essential trace element, and it's a cofactor in multiple processes in our body, starting just not with DNA synthesis, but iron also plays a role in oxygen transport, obviously with hemoglobin, as well as mitochondrial cell respiration and even ATP formation. So we need iron for basically, almost every metabolic process in our body. But iron overload can be toxic. So we all know that iron deficiency anemia is a huge issue, and it's very, very common worldwide because our body has this very complex mechanism for maintaining iron homeostasis. And because of that, it's very common for individuals to be iron deficient. So the proteins that regulate iron metabolism and hemostasis in the body include hepcidin. So hepcidin is the primary regulator of our systemic iron homeostasis. And it's interesting that hepcidin has an inverse relationship with iron bioavailability. So hepcidin is increased in cases of stress like chronic inflammation, as well as chronic kidney disease. And so in those cases, the increase in hepcidin results in a decrease in systemic iron bioavailability. And so that's why we have functional iron deficiencies in these patients. Even though they may have adequate iron stores, the iron is not available for use in the body. All right, so again, we all know this. Historically, we've treated iron deficiency anemia with oral iron, and oral iron is wonderful. It's sort of like the transfusion of blood products. We all sort of learn it early on in our clinical practice, and it's cheap. So it's great for resource poor settings, but it has a lot of issues. So it requires long-term treatment. So 3 to 6 months to replete iron stores. And associated with that long-term administration of iron is that it does have adverse effects that occur in almost 3/4 of patients that take oral iron formulations. We talked about hepcidin before. The daily dosing of oral iron results actually in increased hepcidin levels. And so you have a decrease in your oral bioavailability the day after you take oral iron. So you actually have decreased systemic absorption. So because of this, a lot of references will recommend alternate day dosing to enhance your iron absorption through a transient decrease in hepcidin levels. And then from a medical toxicology perspective, I treat a lot of patients with lead poisoning, and lead interferes with some of the enzymes involved in heme biosynthesis. And so patients with lead poisoning are frequently iron deficient. This is largely noted in the pediatric population. We do have adults that have lead poisoning, but again, it's mostly kids. The pediatric medical groups have been pretty slow to appreciate the use of IV iron, I think because of some perceived safety concerns. So they will mostly treat the children with oral iron. And I usually will tell the parents to offer fruit with every meal because giving vitamin C along with oral iron can almost quadruple its absorption. So this is something that I frequently will recommend. All right, so we'll move on to IV iron. So intravenous iron formulations are composed of a central iron core surrounded by a carbohydrate shell. Again, I think we all know this. The carbohydrate shell composition is what differentiates the iron products from each other. This is just a picture from the internet that I found. You see in the column on the left, there's the middle column actually has the trade names that we're all familiar with. And then the column on the right has the specific carbohydrate shell compositions that set each product apart. The initial IV iron formulations were introduced in the early 20th century, starting with colloidal ferric hydroxide. In these formulations, the carbohydrate shell didn't really hold in the iron core tightly, and so it allowed for large amounts of release of free or elemental iron, and this caused toxicity, again, because elemental iron overload can cause a lot of cellular damage, lipid peroxidation, and a lot of problems that way. So there were a lot of toxicity issues. So the newer formulations of IV iron are constructed to prevent rapid release of elemental iron. So you get a much slower release. The carbohydrate shells are often very large, especially in some of the much more recent formulations. And this allows for really slow and sustained release of free iron. So it's interesting, if you remember, maybe 20 years ago or so, we had a lot of issues with high molecular weight iron dextran. Well, and that was causing anaphylactic reactions. Well, the higher molecular weight formulations of the currently available intravenous iron infusions are actually a lot less labile than the lower molecular weight formulations. They cause much more slow release of the iron because they're large, and the iron core actually just cannot get mobilized as easily. So this is why we can give much larger dosings of the newer high molecular weight formulations like ferric carboxymaltose. We can give like 1 gram or more without having significant infusion-related adverse events. This is a nice graph that I found of the different IV iron formulations and their relative labilities. So you can see that ferric carboxymaltose over on the far left has a very low lability compared to iron sucrose and iron gluconate, which have much higher labilities. And on the next slide, you'll see that they actually have, I think they actually are lower molecular weight than ferric carboxymaltose. Actually, I do not have that slide, I'm sorry. But I do have a slide from SABM of the currently available iron formulations in the US. And, we all have our favorites. You can take a look and see what your institution uses. Everyone sort of uses different things. And because I work in the system-wide patient blood management area here, I am focusing on our individual MedStar institutions. And I noticed that they all, for the most part, they may use different formulations of IV iron. So we currently have iron dextran, we have iron sucrose, ferric gluconate, ferromoxetol, and then ferric carboxymaltose. And you can just, take a minute to think to yourself what your individual institution or institutions use and why you use them. The different institutions use different formulations, and this is based on multiple factors, including but not limited to the safety of the specific formulation, as well as the cost of the formulation. Physician preference definitely comes into play. If you have a physician or a pharmacist who sits on P&T, they will have a definite impact in the iron formulation that's adopted by the hospital. And then we have to think about the ease of administration. So these are the discussions that come up in our management team meetings, where we talk about, why we prefer one IV iron formulation over the other, and whether we should have a unified system-wide IV iron formulation. So this was a discussion that came up recently. We had a discussion about low molecular weight iron dextran, or NFED. So we have one hospital in our system that uses a lot of low molecular weight iron dextran. And the reasoning is that it's single dose administration, which is great. So you can, take these patients and do an infusion clinic, and you can give them 1 dose, maybe 2 doses if you need to, and you can fully replete their iron stores. It sounds great in theory. So why haven't we adopted it in all of our hospitals? Well, the main reason is the ease of administration issue. So this is the prescribing information, the package insert for NFED. And you can see that it says that prior prior to the first dose, you should administer a test dose. And that test dose needs to be administered, and then you need to observe the patients for at least an hour before you give the therapeutic dose. So we all know that, especially in recent times with COVID-19, nurses are leaving the profession in droves, and there's a nursing shortage in the US. It's very significant. Hospitals are closing ICUs and closing units and having a lot of issues because of this lack of nursing. So at least at my hospital, our nurses are pretty short-staffed, and they don't have the time. They actually didn't have the time to do this even a couple of years ago, but they don't have the time now, especially, to sit and observe patients for an hour after giving them a test dose of low molecular weight iron dextran. So because of this, we have not really adopted the use of this product at our hospital. At other facilities where people have infusion clinics and they have different staffing patterns, maybe it's a little bit easier to use low molecular weight iron dextran. But this is something that came up in a discussion in the last couple of months at one of our system-wide meetings, where we really got into the details about this. And besides the low molecular weight iron dextran, another issue that came up was sodium ferric gluconate. All right, so UpToDate is something that you may all be aware of. It's a computer-based medical reference that a lot of residents and attendings will use just to get a quick synopsis of a particular topic in medicine. Many institutions have institutional subscriptions. So if you look at UpToDate and go into anemia and pregnancy, this is what you see. So you see that UpToDate recommends against the use of sodium ferric gluconate for pregnant patients because of the presence of benzyl alcohol as a preservative. So this is really significant because a lot of people refer to UpToDate and use it as a primary medical reference. And if you are at an institution where sodium ferric gluconate is on your formulary and is your primary or maybe your only source of IV iron, you might be very concerned about using this in pregnant women who, again, often are iron deficient and do need treatment. So we're going to talk about this. So I took a look first at the references in UpToDate. So what is the evidence that UpToDate gives for not using sodium ferric gluconate? And they list two references, which are right here. So they have an article referenced about benzyl alcohol toxicity, the impact on mortality and intraventricular hemorrhage among very low birth weight infants. And then they also have a reference about evaluation of 60 chemicals in a developmental toxicity test. I don't see any mention of benzyl alcohol in that attribute. I'm going to sneeze, I'm sorry, excuse me. Maybe not. All right, so we're going to talk about benzyl alcohol. So what is benzyl alcohol? And here's where I get to sort of geek out and go into my toxicology background. So benzyl alcohol is an aromatic alcohol. Here's its chemical structure. It's a pretty small molecule, so it has a low molecular weight. This will come up later on in this talk. It's colorless, it's a liquid, and it has a sweet odor. It's actually used as a fragrance. We'll talk about this in a minute, but it's used as a fragrance because it smells sweet. It's also used as an antiseptic, as a preservative in IV or parenteral medications, and it's actually bacteriostatic against multiple bacteria and fungi. So it has activity against Aspergillus, against Candida albicans, against E. coli, Pseudomonas, Staph aureus. A lot of the bad bugs that we worry about in the hospital setting can be inhibited through the use of benzyl alcohol. Interestingly, there's also some literature in emergency medicine about using benzyl alcohol as an anesthetic agent. I just thought that was a little out there, but it's very interesting. So how is it used and where does it come from? So benzyl alcohol is a natural constituent of the essential oil of jasmine, as well as balsam of Peru. So I just want to mention the definition of essential oils. People frequently are unsure what it means. Essential oils are not like essential for life or anything like that. They refer to the essence of a plant that gives the plant its particular smell. So keep that in the back of your mind. So benzyl alcohol is found in many cosmetic products that we use every day. I was probably exposed to benzyl alcohol this morning getting ready for work. It's used as a preservative, as a solvent, as a viscosity reducing agent, and it can even be used in products that are listed as being fragrance-free. Now remember, benzyl alcohol has a sweet smell, so how can it be listed in a fragrance-free product? Well, the answer is the U.S. Code of Federal Regulations lists fragrance or defines fragrance as something that's added to a product solely for the purpose of changing its smell. So if benzyl alcohol is used as a preservative, it can still be listed in as not a fragrance and still be used in fragrance-free products because it's not being used only to impart a smell to the particular product. So I thought that was pretty cool. But again, because it has a smell and an odor and a taste, it can cause allergic reactions. It is a well-known cause of contact dermatitis, and there's many reports of contact dermatitis from benzyl alcohol in the dermatology literature. And then here's just some products that have benzyl alcohol in it. So we are putting benzyl alcohol containing formulations on babies when we use Aveeno baby lotion. Those of us that use moisturizing creams like Cetaphil, again, you can see on the bottom of this product, it's listed as fragrance-free. It has benzyl alcohol in it. So benzyl alcohol is present in our daily lives. So yesterday I took a break from, work, and I went to breakfast with my husband at this nice little French restaurant, and we went to sit down, and I saw this product for sale called Confit of Jasmine Flowers. And I was like, I just recently looked up jasmine for this talk. So this is kind of cool. So I took a look at the back of the product. It's kind of expensive. And look at that. It contains natural jasmine aroma. So remember that the essential oil is the part of the plant that relates to its aroma and its fragrance. So this product that you can buy and eat actually contains benzyl alcohol also. So I thought that was interesting. All right, so in pharmaceutical products, benzyl alcohol is used as an excipient in multiple dose formulations. So we've all heard of excipients or inactive ingredients like thimerosal, which contains mercury, and there was a lot of controversy about that in vaccines. So benzyl alcohol is a similar product. The definition of an excipient is a material other than the active ingredient added to the product used in the preparation or formulation of a drug product. So benzyl alcohol is basically just an inactive ingredient used as a preservative. It's present in these 0.9% sodium chloride multiple dose injectable flushes that we all see in the hospital on a daily basis. If you take a quick look at the product label, it actually does have a little red box that says not for use in neonates, and we will talk about why. So in the early 1980s, there were a total of 16 neonates that died while under care in NICUs in the US. These were really, really low birth weight babies. They weighed, there were two case series reported. In the first case in the New England Journal, the maximum weight was 2.2 kilos. In the second case, the maximum weight was 1.25 kilos. So these were sick kiddos. They were very low birth weight. They had a lot of medical comorbidities, but it was a little odd that within a short time, 16 of them died in two separate institutions. The clinical picture of these babies was gradual neurologic deterioration that was followed by severe metabolic acidosis and gasping respirations. These babies then developed hematologic abnormalities, multi-organ failure, and then death followed. Autopsy results really didn't reveal a cause of death, and so these institutions where the deaths occurred took a much closer look at the factors involved in these fatalities. The clinical presentation was termed gasping syndrome because of the gasping respirations, which was most likely the respiratory compensation for the metabolic acidosis that the infants exhibited immediately prior to their deaths. Interestingly, all of the affected infants had received multiple injections of heparinized 0.9 sodium chloride solutions as a flush for their central venous catheters in the days prior to development of symptoms. And the flush solutions contained 0.9% benzyl alcohol. An analysis of the affected infant's urine and blood determined the presence of benzyl alcohol, as well as really high concentrations of benzyl alcohol metabolites. And so benzyl alcohol was suspected as the cause of death in these patients. So they went back and they took a look at the doses that these infants received. And in this one report from the New England Journal that reported on 10 babies, the infants that developed gasping syndrome received a total of 99 to 234 milligrams per kilogram of benzyl alcohol each day prior to the development of symptoms. So the New England Journal authors took a look at a matched control group of 8 infants who received benzyl alcohol containing solutions, but did not develop gasping syndrome. And in those infants, they all received doses of less than 99 mg per kg. So 99 mg per kg per day of benzyl alcohol for these neonates was sort of thought of as the triggering dose for the development of gasping syndrome. And these institutions basically stopped using benzyl alcohol containing bacteriostatic sodium chloride, and they didn't have any additional cases of gasping syndrome reported. This led to the US FDA issuing an advisory that recommended that hospitals not use benzyl alcohol containing solutions in premature infants. All right, so why did these deaths happen? Well, first of all, these infants were very, very small birth weight, as you recall, and they were getting really, really big doses in a milligram per kilogram analysis of benzyl alcohol. There's also a thought that maybe these infants had immature enzymatic systems that resulted in a decreased capacity for them to metabolize benzyl alcohol. This is the metabolism of benzyl alcohol in the human body. So benzyl alcohol is initially metabolized through an oxidative pathway to benzaldehyde, which then goes on to benzoic acid. Then the benzoic acid, which actually is a toxic byproduct, is conjugated with glycine to form hippuric acid. Hippuric acid is completely non-toxic. We pee it out, we eliminate it renally. So the issues in this case was maybe the infants were able to rapidly convert the benzyl alcohol to benzoic acid, but they weren't really able to detoxify the benzoic acid. And so that was why they had these high levels of benzoic acid as well as the metabolic acidosis. And we do know that neonates do have very immature enzymatic systems until about 6 months of age. So definitely there could be some aberrations in their glycine stores. So what are some of the maternal fetal ramifications of this? Well, first of all, when you give a drug orally, it passes through the liver and goes through first pass metabolism. When you give a drug IV, like these IV iron formulations or IV benzyl alcohol, you are getting 100% absorption. And so after benzyl alcohol is administered IV to adults, despite that 100% absorption, the conversion to benzoic acid occurs very, very rapidly. And the half-life in the body of benzoic acid and hippuric acid is very short. So it takes about 5 half-lives to fully get rid of a product in the body. So if you take the maximum half-life of hippuric acid here for 31 minutes, so after about 150 minutes or just over 2 hours, you're going to basically have no more of these products in your body. So it's a very rapid metabolism, very rapid elimination. So this probably significantly reduces fetal exposure. Also remember that we're being exposed to benzyl alcohol in cosmetics and lotions and foods and everything else on a daily basis. So it's likely that pregnant women are being exposed to benzyl alcohol without even knowing it. And we're not seeing these large reports of benzyl alcohol toxicity. And again, you do get some absorption, pretty significant absorption of benzyl alcohol through the skin. So even if you're putting lotion on your skin or lotion on your baby that contains benzyl alcohol, it's not causing toxicity as we know it. So probably in lower doses for pregnant women and for infants and even neonates, benzyl alcohol is relatively safe. So there have been some additional cases reported in the non-neonate population of benzyl alcohol toxicity. There was a 5-year-old girl who died after she received diazepam for 36 hours to treat status epilepticus. She had metabolic acidosis noted prior to her death. There were elevated benzoic acid levels found in her serum and urine. Her estimated benzyl alcohol dose was about 180 mg per kg per day. So well above that 99 mg per kg. So that's a significant dose, but diazepam also contains propylene glycol as an excipient, which can also metabolize to lactate and cause a lactic acidosis. There was also a report of a 53-year-old man who died after receiving high-dose etoposide for chemotherapy. He had metabolic acidosis right before he died. His estimated benzyl alcohol dose was about 90 mg per kg. The authors of this report thought that he probably had some sort of polymorphism in his alcohol dehydrogenase, where he was able to most likely rapidly metabolize it to benzoic acid and then had difficulties clearing that. There's your references in case you want to look these up. So let's talk about sodium ferric gluconate. So this is the prescribing information for sodium ferric gluconate. It does contain benzoic acid, and it's interesting that the prescribing information says use only if clearly indicated in pregnancy. This is farther on in the package insert, and there's actually a dose listed. So Ferlicit contains 9 milligrams of benzyl alcohol per ml. So let's think about our sodium ferric gluconate dosing. So the standard dose is about 10 mLs, and that gives you a dose of 125 milligrams of elemental iron. We will sometimes double this at our institution to give a dose of 250 milligrams elemental iron. If you're using a standard dose of 10 mLs, if you multiply that by the benzyl alcohol content, you get a benzyl alcohol dose of 90 milligrams per dose of Ferlicit. If we're giving a double dose, like we sometimes do, that's 180 milligrams of benzyl alcohol. So it's not a huge dose. And for a 70 kilogram adult, this equates to an IV benzyl alcohol exposure of about like 1.3 to 2.6 milligrams per kilogram, which is well below that 99 to 234 mg per kg per day that the neonates were getting when they develop gasping syndrome. remember that the neonates that received doses of less than 99 mg per kg per day did not get gasping syndrome. And so it's actually probably quite likely that a standard or double dose of sodium ferric gluconate is not going to result in significant toxicity to the fetus of a pregnant woman. Some additional concerns, drugs with low molecular weights are more likely to cross the placenta, so that could be another question. The molecular weight of benzyl alcohol is pretty low, it's only 108, so it's likely that it does cross the placenta, but even in drugs that cross the placenta, the fetal dose is much, much, much smaller than the maternal dose. So it's probably not significant that the benzyl alcohol content of ferric will cross the placenta and get fetal exposure. And because of this, so sodium ferric gluconate is classified by the FDA as pregnancy class B. So we can use it in pregnant women. We don't have any well-controlled studies in pregnant women, but we also don't have studies in animals that show a risk to the fetus. So I think that we can establish that sodium ferric gluconate should be safe to use in the pregnant population. And if this is a drug that your hospital has on formulary, I think that if you have an alternative that does not contain benzyl alcohol, like any of the other formulations, it's probably best to use those. But if all that you have is sodium ferric gluconate, I think you're okay.